Welcome to this update on therapeutics for COVID-19. I'm Dr. Daniel Kuritzkes, Chief of the Division of Infectious Diseases at Brigham and Women's Hospital and Professor of Medicine at Harvard Medical School here in Boston. This slide shows my disclosures. Today I'm going to be discussing several different approaches as treatment options for COVID-19. None of these has yet been proven to be effective therapy for this infectious disease, but there are numerous studies ongoing around the world, and I'll try to provide an update on as many of them as we can cover. This list is certainly not exhaustive, and in future updates, we'll try to cover additional topics. Let's start with antiviral therapeutics. This slide shows a schematic of the life cycle of SARS-CoV-2, the virus that causes COVID-19. SARS-CoV-2 is a single-stranded RNA virus that is enveloped, and the S or spike protein of the envelope engages the angiotensin-converting enzyme 2 as its primary receptor. This results in entry of the virus particle through endocytosis into the cell where it undergoes uncoating. And the process of exiting the vesicle may be inhibited by agents that prevent acidification of the vesicle, such as hydroxychloroquine. The RNA is then reproduced by an RNA-dependent RNA polymerase, and several of the drugs that are being studied as potential therapeutics are RNA polymerase inhibitors. Following RNA transcription and reproduction, there is a translation of RNA into proteins, which need to be processed, as is the case for many viruses. Then the virus buds out and can go on to infect other cells. One of the first antiviral drugs to be studied was lopinavir in combination with ritonavir, the HIV protease. There's a question about why lopinavir might have any activity against SARS-CoV-2, since the HIV protease is an aspartyl acid protease, whereas the SARS-CoV-2 enzymes are serine proteases. However, there was some in vitro evidence, as shown in the upper right panel here, that lopinavir has antiviral activity against SARS-CoV-2 with an EC50 of just under 12 micromolar. There have also been retrospective case control series suggesting a benefit of lopinavir in the original SARS outbreak of nearly a decade ago. This led to a randomized clinical trial that was conducted in China, comparing lopinavir-ritonavir to a placebo, which was published in the New England Journal of Medicine several weeks ago, and showed no benefit overall in terms of survival. Interestingly, though, there did seem to be a potential benefit in patients who received treatment after fewer than 12 days of illness, so those who were treated earlier. And so there may still be some room to explore use of lopinavir in earlier stage patients. The drug that's perhaps received some of the most attention is hydroxychloroquine. This, of course, is a drug that serves as both an antimalarial, it's a derivative of chloroquine, as well as an anti-inflammatory drug that's widely used for the treatment of lupus and rheumatoid arthritis. There are two potential modes of action for hydroxychloroquine. One is as an antiviral drug through its inhibition of acidification of endosomal vesicles, and the other as an anti-inflammatory, perhaps moderating some of the inflammatory consequences of SARS-CoV-2 infection. Shown in the upper right panel here are data inhibition curves for hydroxychloroquine and chloroquine in vitro inhibition assays, and you can see that the EC50 is at around 4 micromolar. There have been mixed results from clinical trials reported to date. A report out of France suggested that there was more rapid shedding, more rapid loss of shedding of SARS-CoV-2 in patients treated either with hydroxychloroquine alone, shown in this blue line, or hydroxychloroquine plus azithromycin, shown in the green line, compared to patients who received no treatment, shown in the black line. However, there were some concerns around potential bias in the way that these studies were conducted, because some patients had progression and ended up in the intensive care unit and were no longer sampled and therefore removed from the analysis. And subsequently, these data have actually been retracted, and other data presented that show no effect of hydroxychloroquine on viral shedding. Nevertheless, there are several large clinical trials that are underway with appropriate controls, the results of which will provide a definitive answer about whether or not hydroxychloroquine is effective. There are concerns, however, about the use of hydroxychloroquine, either alone or in combination with azithromycin, in terms of the effect of these drugs on cardiac conduction, specifically prolongation of the QT interval. You can see here in this very recently published paper from JAMA Cardiology that nearly everybody who received hydroxychloroquine had an increase in the QTc, with some patients having intervals that increased above 500 milliseconds, those shown in orange. If they received hydroxychloroquine with azithromycin, you also see a substantial increase in a subgroup of patients reaching more than 500 milliseconds. In this study, one person in the trial did develop torsade de pointe, which of course is the ventricular arrhythmia of greatest concern in patients with QTc prolongation. There have also been preliminary data, still unpublished but posted online, showing that at least with hydroxychloroquine alone, there was actually an increased mortality compared to those who received neither hydroxychloroquine nor hydroxychloroquine with azithromycin, and this was statistically significant. However, this study was not a randomized trial, and there could very clearly have been allocation bias where the sickest patients received drug. So we really won't know whether hydroxychloroquine has a benefit or it has more harm than benefit until we see properly conducted randomized placebo-controlled trials. Let's turn briefly now to talk about Favappear. This is a broad spectrum viral RNA polymerase inhibitor. It's been approved for use against influenza in Japan, but not yet in the United States. This drug has activity against SARS-CoV-2 in the laboratory, shown again in the upper right panel of the slide, but with an EC50 of about 62 micromolar, substantially greater than what was seen for hydroxychloroquine or even for lopinavir. This is a concentration, however, that is achievable with dosing in humans using the dose approved for influenza. And a non-randomized pilot study showed more rapid clearance of SARS-CoV-2 from pharyngeal secretions of patients compared to those who received lopinavir, and there are now several trials underway. The drug that has shown the greatest promise to date is remdesivir. Like favipiravir, remdesivir is an RNA polymerase inhibitor with in vitro activity against a range of RNA viruses, including Ebola, SARS, MERS, and SARS-CoV-2. Remdesivir was actually studied in a phase 3 trial against Ebola, where it proved to be inferior to broadly neutralizing antibodies. However, as shown in the upper right-hand panel, remdesivir is really quite potent against SARS-CoV-2 with an EC50 just below 1 micromolar. And in studies done in murine models and in non-human primates, the drug has been shown to protect against lung injury. These photomicrographs here show what the lung looks like in animals that just received the control, where you see lots of inflammation and accumulation of fluid compared to the remdesivir-treated animals that had some inflammatory cells, but the alveoli remain relatively clear, and then in the left panel, mock-infected animals. In addition, in the non-human primate studies, compared to the control, infected monkeys who received remdesivir for treatment had significantly lower virus loads in their secretions. And when given as prophylaxis, it was highly protective against acquisition of SARS-CoV-2 infection. Preliminary data from a compassionate use study of remdesivir were published a couple of weeks ago in the New England Journal of Medicine. This study didn't have a control arm, so we're really just looking at overall survival and improvement and discharge. And approximately 68% or so of participants showed improvement and were discharged home if they received remdesivir, and that's compared to about 30% of similar patients from the experience in Wuhan. Obviously, that's a very difficult comparison to make because this was a US-based study done several months after the data had been collected in Wuhan. But even if you looked here in the middle panel at those who required invasive ventilatory support, the survival rates for those who received remdesivir were substantially greater than those that had been reported previously. There are now quite a few different remdesivir trials that are ongoing or have been reported either completely or in various stages. Those include the compassionate use protocol, whose data I just showed you, data from the ACT-1 study, which was a randomized clinical trial of remdesivir versus placebo for patients who had significant hypoxia or requiring supplemental oxygen or mechanical ventilation along with pulmonary infiltrates. And there were, the total sample size is close to 1,000 participants, but data are now available on a subset of those. Severe disease study in China that has been reported of remdesivir versus placebo in only 237 participants. And then 2 studies being done by Gilead, one in severe disease and one in moderate disease. The study that has received a great deal of attention since it was first preliminary data were released last week is the ACT-1 study. This is a study sponsored by the US National Institutes of Health. And it is a randomized, double-blind, placebo-controlled, multi-center study in hospitalized patients with COVID-19. Patients were randomized to receive either a loading dose followed by daily intravenous remdesivir for up to 10 days or placebo, the primary outcome being time to recovery over the first 28 days. The data that have been released thus far show that looking at time to recovery, there was a 31% reduction in time to recovery, which was highly statistically significant, 11 days versus 15 days for placebo. This led the DSMB to halt the randomized part of the study because a significant advantage was demonstrated for intervention. However, there has not yet been demonstration of a survival advantage. There was a numerical advantage with only 8% of remdesivir treated versus just under 12% of placebo recipients dying. And that just missed being statistically significant, but we'll really need to see the outcome from the entire data set to know whether there is, in fact, a survival advantage or not. In addition, Gilead released data from its severe trial. Remember, this was a study done in people who had O2 saturations of less than 94% on room air, or who required supplemental oxygen to maintain an SaO2 of 94% or greater, or were receiving mechanical ventilation. And this study compared 2 different durations of therapy of the same dosage of remdesivir, either 5 days or 10 days, but there was no placebo group. What the study found was that overall, there really was no statistically significant difference between the shorter and longer course of therapy. Therefore, that study has been completed, but continues now in a open label format where participants continue to be accrued, and if they are on a ventilatory support, receive up to 10 days of intravenous remdesivir. A study in China has been done that is a randomized clinical trial of remdesivir versus placebo in severe disease. That one, like the Gilead study, required, and like the ACT study, required an SaO2 of 94% or less and the presence of pulmonary infiltrates. However, the study was terminated for futility due to under-enrollment because the epidemic in Wuhan came to an end prior to the time that the study could be fully enrolled. So what we really have are top-line results that were unintentionally released by the WHO and then removed from their website. But what we can glean from that transient posting is that the hazard ratio for time to clinical improvement really did not achieve clinical significance. You can see the confidence bounds cross 1. And there was also no advantage in terms of 28-day mortality. And remdesivir was stopped early for adverse events in just under 12% of participants compared to 5% who had to stop a study drug in the placebo arm. Now, in placing these results in context with the ACT-1 study and the Gilead uncontrolled study in severe disease, it's important to note that this study was terminated before reaching full accrual. So it's really an underpowered study and doesn't really contradict the results of the ACT-1 study. As a consequence of all of these data, remdesivir is now released under an emergency use authorization in the United States for use in patients whose clinical characteristics match those of participants in the severe trial. That is, an O2 saturation of 94% or less on room air, or needing supplemental oxygen, or being on mechanical ventilation or extracorporeal membrane oxygenation. The distribution of this drug in the United States is still somewhat uncertain because it is being handled by the US government rather than by the manufacturer, and the mechanism for accessing drug remains controversial. The important points are that for patients who meet entry criteria, if they are mechanically ventilated, then 10 days of treatment are recommended, and if they are simply on supplemental oxygen, 5 days of treatment are being recommended. Also of note, the drug can be started even while awaiting results of SARS-CoV-2 testing in order to start drug as early as possible. This EUA is being administered not as a clinical trial, so participants or patients don't need to give consent, but they do need to be provided with a fact sheet about remdesivir. It's important to be monitoring renal function and liver function tests for patients who are receiving the drug, and the drug is not recommended for use in patients with advanced renal insufficiency with eGFRs of less than 30 mils per minute. And treating clinicians are obligated to collect and report serious adverse events in those receiving remdesivir, as well as to report any dosing errors. Well, let's turn to a discussion of anti-inflammatory drugs. We know that the illness caused by SARS-CoV-2 has several stages, where the initial stage is really dominated by viral infection and then transitions to a pulmonary phase, followed by a hyperinflammatory phase, which is really determined by an exuberant and inappropriate host inflammatory response that leads to and perpetuates lung injury, which requiring prolonged support with mechanical ventilation and often leading to death. So this second phase is characterized by a cytokine storm and very high levels of IL-6, which has led to a number of pilot studies looking at monoclonal antibodies that are able to either bind IL-6 or block the IL-6 receptor in order to interrupt this cascade. And you can see in the panels here on the upper right, data from a pilot study of tocilizumab, an IL-6 receptor antibody, showing decreases in C-reactive protein and decreases in fever among this group of participants in an open label pilot study. In addition, we've seen partial data from 2 studies of IL-6 receptor blockers. Sirillium AB, which acts similarly to tocilizumab, is in a phase 2/3 study, where the phase 2 study suggested a potential benefit for people who were receiving the higher dose of Sirillium AB, 400 milligrams. You can see here that mortality was 23% compared to 36% in the high dose group. And those who died on a ventilator was 32% compared to 46% in the low dose group and 55% in the placebo group. This led the sponsor to modify the phase 3 component of the trial to eliminate the low dose and just proceed with a 2-arm study comparing the 400 milligram dose to placebo. Preliminary data were also released, perhaps unintentionally, from a tocilizumab pilot study in which nearly 130 patients were randomized to either standard of care with tocilizumab or to standard of care alone. This was an open label study. There was a significantly lower proportion of patients who reached the primary outcome in the tocilizumab arm. This release has generated some controversy because the results were really interim results. And now there is a larger, actually several larger tocilizumab studies being done by different groups around the world. And we await the results of those trials. With those preliminary data, there has been a literal flood of additional drugs targeting various aspects of the inflammatory cascade that have entered into clinical trials, including many different monoclonal antibodies, as shown in this column on the left, several of the JAK inhibitors or Bruton tyrosine kinase inhibitors, as shown in this middle column, and other agents such as abatacept, as shown in the right-hand column. And these are only the studies of which I am aware. There are undoubtedly many others that are ongoing. Well, what about the renin-angiotensin-aldosterone system and its role both in disease and potentially as a therapeutic target? As we discussed at the beginning of this talk, we know that the SARS-CoV-2 virion binds to angiotensin-converting enzyme 2, the primary receptor for the virus. When the virus binds to the receptor, this causes downregulation of receptor expression. The enzyme, however, is crucial for metabolism of angiotensin 2, which is part of the angiotensin cascade. When angiotensin 2 is not metabolized by ACE2 to angiotensin 1,7, the breakdown product, this leads to unopposed action of angiotensin 2, which can bind then to the angiotensin 2 type 1 receptor, and leading to acute lung injury, adverse myocardial remodeling, vasoconstriction, and increased vascular permeability. On the other hand, blocking the angiotensin 2 receptor leads to an increase in ACE2 expression, which might potentially facilitate virus entry and make infection worse. So there's been a big question about how the balance between expression of angiotensin 2 and blockade of angiotensin 2 receptor might play out in people with COVID-19. We have some preliminary data that are reassuring. These are data from China, roughly 1,100 or 1,200 patients who were followed, who continued receiving either an ACE inhibitor or an angiotensin receptor blocker because of hypertension during their hospitalization for COVID-19. And in this study, there was actually lower mortality among those who continued to receive these drugs compared to those who were not receiving these drugs after controlling for other covariates, including the presence of hypertension. In addition, a recently published paper in the New England Journal of Medicine looking at data from the United States and analyzing the independent predictors of in-hospital death in a multivariate logistic regression analysis, examined the association of ACE inhibitor, angiotensin receptor blocker, or statin use at the time of hospital admission. Now, they didn't necessarily determine if people continue to receive these drugs, but people were getting these drugs at the time of admission. And you can see that there was significantly lower mortality for those receiving an ACE inhibitor or a statin, and no effect on mortality for those receiving angiotensin receptor blockers. So in aggregate, these data are quite encouraging that one can continue to use these drugs safely, whether they have a therapeutic role in people who don't require them for management of hypertension has not yet been answered. Let's talk briefly about convalescence serum. Convalescent serum from survivors of COVID-19 infection may contain high titers of neutralizing antibody, and this type of serum has been shown to have some benefit in the treatment of avian influenza, in epidemic H1N1, and in MERS. And an uncontrolled study published several weeks ago in JAMA showed that in 5 participants who received convalescent serum, 4 of these 5 were successfully weaned from the ventilator. They showed reductions in the shedding of virus, as shown by increasing cycle times required to detect virus by PCR. They had decreases in their multi-organ dysfunction score, improvements in oxygenation, and reduction in fever. There are some theoretical concerns that unless very carefully selected, these plasmas could also contain enhancing antibodies that might make the situation worse. And of course, there's also the concern for serum sickness and for transfusion reactions. But there are now many clinical trials underway around the world at multiple centers of a convalescent serum, and those results are awaited with great interest. Let me end by summarizing some of the challenges in conducting clinical trials of therapeutics in for treatment of respiratory viral pathogens. As we have come to learn from studies of influenza, it's clear that the benefit of antiviral drugs is maximal when the drug is started within the first few days after symptom onset. We also know that accelerated viral clearance from respiratory secretions is not necessarily a surrogate marker for clinical improvement with treatment of an antiviral drug. Immune-mediated lung injury is unlikely to be modified by antivirals, so when antivirals are started late, their benefit may be substantially less than when started early. And the availability of several candidates as approved drugs that can simply be prescribed, such as hydroxychloroquine, complicates the conduct of clinical trials where we're attempting to use these drugs in a controlled manner in order to obtain really valid data about their efficacy. Most likely, combinations of antiviral and anti-inflammatory drugs are going to be required in order to achieve maximal benefit and provide the best outcome for patients with COVID-19. Let me thank you for your attention, and I will turn this back over to our moderator for some questions.